There are many treatment options for acute and chronic Charcot. The aim of treatment of Charcot is to prevent progression of the disease. Complications that may arise from inadequate or delayed treatment include foot deformity, chronic ulceration, and infection. Offloading at the acute active stage of the Charcot foot is the most important management strategy and could stop the progression to deformity. Ideally, the foot should be immobilized in a total contact cast, which is initially replaced at 3 days, then checked each week. The TCC is a custom molded cast, commonly using plaster or fiberglass, which maintains contact with the entire plantar surface of the foot and lower limb. The TCC immobilizes the affected foot and ankle, reduces plantar pressures and swelling, protects from additional trauma, and maintains patient mobility. Edema reduction is often remarkable in the first few weeks of treatment. If possible, the patient should use crutches or a wheelchair and should be encouraged to avoid weight bearing on the affected side. The casting is continued until the swelling has resolved and the temperature of the affected foot is within 2 degrees of the other foot. An alternative device for offloading the acute active stage of Charcot is a prefabricated removable walking cast or an instant TCC technique, which transforms a removable cast walker to one that is less easily removed as plaster is wrapped around the boot. The technique is more cost-effective and requires less skill to apply. Removable cast walkers have the benefit of immediate application without specialist skills and have been reported to be just as effective in offloading the Charcot foot. However, patient adherence is often slightly reduced with these devices. Removable walkers should only be prescribed when TCCs or ITCCs are deemed inappropriate, for example, falls risk, infection, and poor blood flow. Bilateral Charcot is reported in as many as 30% of cases. As stated earlier, mobilization therapy, especially with the use of crutches, has been reported to potentially increase the load on the contralateral foot and thereby predisposes the patient to bilateral acute Charcot. For this reason, support with appropriate footwear and accommodative insoles is recommended for the contralateral foot to minimize the risk of bilateral acute Charcot. Patient education regarding the diagnosis, estimated length of treatment, and expected outcomes is an important component of Charcot management. If the patient understands the nature of this limb-threatening condition, they may be more motivated to adhere to the management plan. Emphasis on the importance of strict immobilization, attending regular follow-up reviews, and optimizing glucose control may improve the outcome of Charcot. During the immobilization period, regular reviews by a high-risk foot service are important to monitor the activity of the acute phase, review the management plan, and assess and manage any secondary complications. Measuring skin temperature differences between the affected and non-affected foot will be conducted. TCC should be recasted and the fit of walkers reassessed at 1/2 weekly reviews to adjust to limb volume changes as the edema subsides over immobilization. Following the initial diagnosis, follow-up radiographs of the affected foot every 4 to 6 weeks will monitor the progression of Charcot, as well as any changes in the alignment and configuration of the foot. Given the complexity of Charcot, a multidisciplinary approach to the holistic management of the patient is recommended. Referrals to a high-risk foot clinic, a local GP or specialist physician to optimize diabetes and other relevant comorbidities. Bisphosphonates may improve the resolution time of the acute phase by reducing skin temperature and disease activity. However, a GP referral is to be made as podiatrists cannot prescribe. It is the last resort for treatment. Once the foot is stable, transition to protected weight bearing is generally advised before the patient steps down to footwear. Aircast walkers or other prefabricated removable walkers have gained acceptance as useful protective modalities for this initial period of weight bearing. Partial weight bearing has been reported to minimize the risk of reactivation of the acute phase if immobilization is ceased too early. Footwear is an important component of the long-term management of the chronic Charcot foot, ensuring that it remains accommodated, offloaded, and protected. In patients with nil to minor foot deformity after the resolution of acute Charcot, prefab footwear with extra depth and a stiff rocker bottom walking sole may be useful. These shoes, when fitted with custom-molded full contact insoles, will adequately minimize load bearing and mobility of the foot during walking. In the presence of moderate deformity, custom-made or modified shoes are generally necessary to accommodate the chronic foot deformity. Again, these shoes will be fitted with a custom insole to minimize load bearing and mobility during walking. Chronic Charcot that has resulted in severe foot deformities and or Charcot that is located in the ankle or rear foot can be difficult to stabilize with footwear and typically requires more aggressive long-term management, such as a Charcot restrained orthotic walker, otherwise known as a crow, to achieve stability and reduce the risk of reactivating the acute phase. The crow has proven to be useful in maintaining foot and ankle alignment. Patient education should form an essential component of the long-term management of these patients, focusing on the importance of appropriate footwear and offloading, regular follow-up reviews, and the risk of further complications. 3 monthly podiatry reviews of these high-risk patients is advised to monitor for signs of recurrent or new episodes of Charcot, as well as any other diabetic foot complications.
Surgery and the Charcot foot. Surgical intervention of CN focuses on the management of the foot deformity but can also encompass the debridement of wounds. It extends further than solely just the operations for reconstructive purposes. Surgical interventions to amputate a Charcot foot is also an option, particularly if there are non-healing ulcers, wounds that continuously break down, or a foot that cannot be reconstructed to a plantar grade stable foot and may require amputation. Debridement of wounds assists in the removal of non-viable tissues such as necrotic or infected tissue. Removing dead tissue accelerates wound healing and can decrease bacterial prevalence. Debridement, whether surgical or sharps, promotes the transformation of a chronic wound into an acute wound to then progress into the normal stages of wound healing. Reconstruction. Internal correction through surgical reconstruction options may include realignment, osteotomy, and arthrodesis to correct the deformity, or an osteotomy to remove or reduce a bony prominence which could cause an ulcer. There are also options for external fixation where patients may have severe osteoporosis and elicit a high complication rate associated with methods of internal fixation. Although the resection of the bone and correction of the foot deformity may still occur, there is an application of a pre-built static external fixator to hold the correction in place. Amputation. Amputation of a Charcot foot can occur when there is insufficient vascular supply to the foot with a recurrent non-healing ulcer, infection, or when the foot may be deemed non-reconstructible. A lower limb amputation may be inevitable for some patients who have unsuccessfully tried conservative treatments. It is widely thought that for many years amputation was the most appropriate treatment for end-stage Charcot's deformity and infection. However, opinions have largely changed and amputation rates have decreased. Amputations are usually below the knee, transtibial or hindfoot amputation. Following an amputation, prosthetics are usually fitted to allow for the continuation of ambulation. Despite this, quality of life of affected patients is lower with lower limb amputations.